Hello everyone, thank you for joining us on this episode of BAEP Talks With. My name is Shantae Worden, the Vice President of the Barbados Association of Endometriosis and P.C.O.S. Now for the month of March, we have a twist this month. Normally we are with one person, but today we have two persons here with us today. Now today I am joined by Dr. John Barker, a specialist obstetrician and gynecologist. He's currently a consultant obstetrician and gynecologist at JRB Medical Centre, number 12, 10th Avenue, Belleville, St. Liverpool. He has completed his postgraduate training in the UK via the Mersey Deanery rotation, Liverpool, and has obtained his certificate of completion of training. He has worked at multiple hospitals in the UK, including the largest standalone women's hospital in Europe. His areas of interest include Gynaecological Oncology, Benign Gynecology, Endometriosis, Emergency Gynecology, Obstetrics, and he is an OSCE examiner at the University of Liverpool, and he's a MOET instructor, that is a Managing Obstetric Emergencies and Trauma. He's a member of the Royal College of Obstetricians and Gynaecologists, British Society for Colposcopy and Cervical Pathology, International Society for Sexuality and Cancer. He has been a registrar in obstetrics and gynecology at the Queen Elizabeth Hospital between 2003 and 2006. Good night to you, Dr. Barker.
Hi, good night, Shanta. Thanks for having me.
Yes, we're so happy to have you here with us. And we're also joined tonight by Mrs. Brenda Roach, a counseling psychologist. Brenda Roach is a registered counseling psychologist. She has a master's degree in counseling psychology from the University of the West Indies, Cave Hill campus, and a certification in psychological first aid from the Johns Hopkins University through Coursera. She specializes in helping her clients overcome grief and loss. This includes the death of a loved one, loss of a relationship due to illness or breakup, loss of financial security, loss of self, and disenfranchised losses such as a miscarriage or being unable to conceive. These types of losses are hidden and not physically seen. Having overcome life-altering losses of her own and using evidence-based interventions that are practical and clinically tested, this has given her the tools to help others to do the same. Brenda currently offers services in the area of grief, trauma, addiction, and behavioral issues such as anxiety and self-esteem. She's the author of Reflecting and Journaling Towards a Meaningful Life, a guided journal entitled A Simple Guide to Daily Journaling, and 2 6-month gratitude journals. She is currently the school counselor at the American University of Integrative Sciences, located in Barbados, and has a practice at the JRB Medical Centre, also located at number 12, 10th Avenue, Belleville, St. Liverpool. Good night to you, Ms. Roach.
Good night, Shantae, and good night, Dr. Barker.
Good night.
Yes. So today we're going to talk a bit about endometriosis, and we're going to delve into the types of endometriosis. We often hear about the different stages, but persons are not really sure about the different types that they may have. And what we're trying to do this year is to speak to a collaborative effort, not only from family members and doctors, but having the psychologists on board, persons like the fertility specialists on board, and I know that that is something that you guys advocate for. So Dr. John Barker, I'm going to let you go ahead.
All right. Now, endometriosis occurs in about 2 to 3 in 10 women. If you read the books, they usually say about 1 to 2. Around about 2 to 3 in 10 women. And essentially what it is whereby cells that are like the ones in the lining of the womb are actually found outside of the womb. They can be found in any place in the body, but most commonly are found in the pelvis. Now, we're just going to limit our conversation to pelvic endometriosis, just to simplify stuff. But essentially, there are usually 3 types. The first type is peritoneal, and essentially what that is that when we look inside your tummy, there's like a cling film that actually covers all the surrounding organs. And essentially what this does is the deposits are found all over this cling film. So the first picture that you saw would have been a normal pelvis, and in the middle is your uterus, and to both sides you see the fallopian tubes and the right ovary. So what I usually tell people is to burn this image inside the head, because this is normal, and at the front is where the bladder would be, and at the back is where the rectum and your sigmoid colon would be. So these are like the intestines, and as you see from this picture, this is a pristine pelvis. So in terms of the types of endometriosis now would be the peritoneal. You can put on the next slide. All right, so essentially what you see there, the spot in the middle, that's a peritoneal deposit of endometriosis, and that is more or less the classic form. So essentially it can find, one can find the burnt out powder spots, or sometimes endometriosis is quite varying and wide. So you can get that one, which is one of the more common ones. You can get like little blebs. You can actually get some scar tissue, which is white, because every month when you get the periods and you get slight bleeding inside your pelvis, and essentially what this causes is inflammation and scarring. So this is the more common type that you might see, but you have to be aware that of the other types, which would be like the clear blebs that you can see, because sometimes you can miss it if you're not actually looking at it. And the picture on your right is essentially what the peritoneum is, and essentially if you can see that little thing that being pulled up, that is the peritoneum. And all of the red stuff that you see in the dots and stuff where the arrow is, that is some deposits of the endometriosis there as well. So essentially that's the first type. Next slide. The next one, and in terms of treatment, what we do is excise it, which would be taking out the abnormal part. Now, this sometimes can be very complex based on where the actual endometriosis deposits are. The thinking behind it is that if you remove the disease, then you can actually start the patient on hormonal contraception to prevent secondary recurrence, versus starting them on medication, hoping that it will quell the disease. If you start them on medication, it doesn't actually quell the disease, but what it does is it quells it, but it doesn't actually remove it. So this is where the excision actually works. Next slide. Now, the second type is what we call endometrioma. And essentially what that is whereby you get a deposit on the ovary itself. And then as a result, what happens is that you get a cyst being formed. Now, usually the current recommendations are that if it's over 3.5 centimeters, then it needs to be removed by a procedure called a cystectomy. And essentially what that is if you have an orange, and the orange peel is the ovary and the actual orange itself is the cyst, essentially what we do is peel the orange away and then remove the actual orange, which would be the cyst. And this will prevent the actual recurrence of the endometrioma. Next slide. All right, now the third type will be the deep infiltrating type, and this is where it will involve like bowel or bladder, and sometimes you can get what you call nodules. So sometimes they can have a combination of all of them in terms of the peritoneal, endometrioma, and bowel. So the picture on the left is the one we saw before, and essentially what this person had was endometrioma plus involvement of the bowel and all the fallopian tubes, all were in the pouch of Douglas, which is the space behind the actual uterus. And the one on the right involves mainly bowel. And as you see, there's no differentiation in the anatomy. Remember the first picture that we saw. So this is a very complex case in relation to dissecting out all the necessary structures, then trying to restore normal anatomy. Next slide. All right, now this is one of the other cases. This would have been the first case that we saw previously with the endometrioma. And this is restoration of the normal anatomy. You can see the bowel at 6 o'clock, and then what you see, the little hole in the middle, that's the pouch of Douglas. And both tubes were checked afterwards and were patent. In terms of the surgery for this, is quite complex surgery because of the structures that we try to separate out. Usually it takes about 2 to 3 hours, sometimes up to 4 hours to actually finish the surgery correctly. Next slide. All right, and in terms of best outcome, essentially a multidisciplinary approach is the best approach when it comes to like the complex cases for the endometriosis. We're fortunate in Barbados to have a team put together to actually tackle this type of disease because it is very complex. And as you can see, it takes a lot of people involved, which would be a specialist gynecologist, colorectal surgeon, urologist, psychologist, pain specialist, physiotherapist, fertility, pediatric adolescent gynecologist. So at least 7 people are usually on the team, and usually mainly it would be the specialist gynecologist like myself and the psychologist and colorectal surgeon are mainly involved in the majority of cases, up to 95%. Depending on the patient's needs, then the other professionals will get involved. And multidisciplinary care improves outcome and offers the best level and standard of care and is evidence-based. And in Barbados, we're trying to manage these people in a multidisciplinary context, be it at the center where I'm at. We are trying to pioneer this approach and being pretty well in terms of outcomes that we're having thus far.
Okay, great. And you would have said that you have a center with you at JRB. And for those who may not know, Dr. Barker founded the Endometriosis Centre there, as he said, at the JRB Medical Center. Now, Dr. Barker, would you say that there is a sector within the public space that would have the same kind of care for persons who may not be able to come to the private sector?
Well, in terms of first world ideal management, what we're doing here mirrors what will be found anywhere overseas. In terms of the model, exactly how we do it is how it should be done. In terms of in the public setting, because it don't work in the public setting, unfortunately, but from talking to colleagues and hearing them talk, they're trying to basically run it like how we try to emulate in terms of the level and standard of care. But you have to remember that it's usually hard to coordinate 7 professionals at any one time. So that is where the issues would come in. Okay.
And I heard you speak about the hormonal therapies that may have to come after persons would have had the excision surgery. I know some men are a bit afraid to take hormonal therapy. I would have heard some persons say, that gives you the polycystic ovaries. Can you explain how that happens or why that happens?
Okay, the polycystic ovarian syndrome is separate from endometriosis. So essentially, with the hormone treatment, what that does is treat pain and try to quell the disease. It doesn't remove the disease. So even if you put the patient on a pill, you give them non-steroidals, you give them Depo-Provera, Mirena coil, all that act equally well in terms of relieving the pain. The only issue is that it doesn't treat the cause of the pain. which would be the endometriosis. So what I usually tell people is that depending on how bad or severe the symptoms are, then surgery would be the best option. For argument's sake, if you want to get pregnant, then any hormonal treatment that we will give you will prevent you from getting pregnant. So that's why we would offer you surgery. In relation to the PCOS, that is a metabolic disorder associated with insulin resistance, in which you have to diagnose it, you have to have 2 out of 3 criteria. And essentially, one would be polycystic ovaries. The second one would be irregular periods or infertility. And the third one would either be signs or symptoms of androgen excess, which is like elevated levels of testosterone in the blood, or what we can, if we look at, say, well, you have a lot of beard, not like me, but not like me. But you have like hair on your chin, or like male distribution of hair on your chest and stuff. So that's how we would diagnose you. But in terms of going forward, treatment for that is usually be the pill to regularize your period and to prevent you from having long-term abnormalities with the lining of the womb, and also to education with diabetes and stuff, because you're at risk for type 2 diabetes and stuff as well.
Okay. Very, very, very good to know that. And you would have spoken about some of the specialists that persons with endometriosis may have to see. In a case like, let's say, a physiotherapist, how would a physiotherapist fit into the care of a person with endometriosis?
Right. So sometimes we refer patients for physiotherapy because sometimes they might have endometriosis. Patients are very complex depending on who you actually deal with. Some are fine, some are not. Some might have other concomitant disorders with the bladder and stuff, so they might need physiotherapy input, or sometimes they might need pelvic floor. They might have pelvic floor issues, so then you have to send them to the physiotherapist. Usually, once they go to the physiotherapist, that usually helps in terms of management of the pain and stuff, in addition to any pain relief that you might give them as well. But we do it frequently, but not as frequent, if you understand me. It's a regular occurrence in terms of sending some of our patients to the physiotherapist. But what most patients need is psychological support.
Yes.
That's my finding in relation to endometriosis patients. And Brenda can tell you more about that.
Yes, she can. And one more question for you, Dr. Barker. Would you say, because I know women hear a lot, okay, if you have endometriosis, you have PCOS, you can't have kids. Or they would say your chances are very, very, very slim. What would you say to that?
I say every patient should be individualized, depending on the severity of the endometriosis. We have done very severe, deep infiltrating endometriosis, and patients have gotten pregnant within a 6 months period. But what you have to realize is that you have to treat both of the diseases separately in relation to the treatment. So if you have endometriosis and think it's pretty bad, then surgery offers you the best outcome. And then in relation to diet, exercise, getting your weight down and stuff will actually counteract the polycystic ovarian syndrome. So sometimes it might not be a magic bullet. Some people might actually take up to 6 months to try and organize the bleeding and stuff. For example, if you have PCOS, you might have very irregular periods. So even if I put you on the pill, you can't get pregnant because you're on the pill. So essentially what we got to do is try and get your weight down and then go from there. And in terms of the endometriosis, depending on if you have blocked tubes or not, we then got to decide if surgery is the best option for you, if you might need IVF. So there are a lot of variables to think about. So every case is not bog standard. Some cases are much more complex than some cases might need at least 4 or 5 professionals at any one time to try and decide which is the best way forward.
Okay, thank you so much, Dr. Barker. And what we like to tell persons is not a one-size-fits-all, as you said. Certain things may work for some, and for others, it just may not work. Now, thank you, Dr. John Barker. We are going to move on to Mrs. Roach. Good night, Mrs. Roach again.
Hi, good night.
Good night. So you and Dr. Barker work together, and as he said, psychological support is one of the most important things that he thinks and he would have seen throughout his clinic. Would you say there are different psychiatric symptoms that women may experience? Because we hear a lot about anxiety and depression, but I am sure there are other psychological symptoms that women may experience.
Yes, that is absolutely correct. So yes, depression and anxiety are the two most common ones, but there are also substance use disorders, because remember, a woman going through that chronic pain every single month, you want something that's going to numb the pain, right? And sometimes some people can turn to substance use. Okay, so that one glass of wine will turn out into a full bottle and so on and so on. And then of course it can become addictive. There's also personality disorders that can come about as well. And what we know about personality disorders is because of a long-term pattern of thinking. So you know you are going through and experiencing this illness for an extended period of time, which then it creates a pattern of thinking in your mind that could lead to the hopelessness or the despair that happens, you know, and is synonymous with the depression, right? So it changes that pattern of thinking that a woman would have when she has such a chronic illness, always thinking that, you know, there's no hope, there's no way that she will ever recover from this, that she will ever lead a normal life, that kind of thing. So yes, so depression, anxiety, and then substance use disorders, and then some personality disorders as well.
Okay, I'm sure that persons were never even thinking about the personality disorders. That is very, very interesting. Now we would have heard, I'm sure many of us that live with endometriosis would have heard that we imagine things, right? And would you be able to tell us if there's a relationship between the psychological factors and the severity of the pain that they experience?
And I think that goes into perception of pain, because we all know that everyone, like Dr. Barker was saying, and you were saying before, everyone experiences it differently. Some women, they may be able to manage the pain from month to month. And so the pain levels, or I should say, our tolerance levels get a bit higher, you know, especially when you're experiencing chronic pain. So high levels of anxiety and depression can amplify the severity of the pain that you do get, right? But as it relates to that perception of pain and understanding the relationship between the psychological factors, there still needs to be more research done, because there's not enough research that will tell us exclusively that yes, that perception of pain and the psychological factors are linked.
Okay, and I can attest to that, because over the years of having endo, my tolerance for pain has become so high now that certain things don't work anymore. Doctors in the public sector would have said, you know, we can't give you anything else other than morphine. That's the highest we can do. So that not working, your body has to try to, you know, just function without the highest level of medication possible. So I can really relate to the fact that women, their body's condition to handle the I find a lot of times persons, they will say, oh, well, you don't just take medication. Why are we saying that?
Yes.
When you're taking these medications, you're not able to function on a daily basis. You're not able to do simple things in life when you're just constantly on medication all the time. So I can truly relate to that.
And you look like the type of person that would smile through the pain, right?
Yes,
and so obviously, yep. And so then obviously then that means that people are looking at you and they're thinking, well, she can't be in so much pain, right? Because she's smiling through it, not knowing that because you've been living with it for so long, that your tolerance for pain has become a lot higher.
Yes, and funny enough, you said that. I remember one time I would have ended up in accident emergency with a ruptured cyst. And the nurse said to me, on a scale of 1 to 10, how bad is the pain? I said it's about 11. And she looks at me, she's like, are you understanding what I'm saying? I said, yes, I understand what you're saying. Because I'm just sitting there like, just get me on the drips now, like just bring the morphine and the Boralgin, just you know, hurry up. And she was in shock. She was like, okay, I'm gonna give you a shot of Voltaren so the doctor can see you. That didn't do anything. But yeah. So it's funny enough that you brought that up. Now, can the high levels of anxiety and depression, as you said before, that it affects the level of pain, right?
Yes.
Okay. So my next question to you is, how important is it for there to be a multidisciplinary team? From your perspective, I'm going to let Dr. Barker put in his own thing.
I think it's really important because, like Dr. Barker said before as well, the condition is a complex one. And so we have to take it on a case-by-case basis. There are some women who I interact with who seem to be okay. They're managing okay. They've lived with it. They are coping as best they can. They have their own coping strategies in place and they seem to be okay. They have a good, robust, strong support system behind them, people who will rally behind them when they are down. There are others who don't have that. There are others out there who are ridiculed, who are looked down on in society by family members as well, who just typically really do not understand the extent to which a woman is going through, right? And so I think that the multidisciplinary approach to this condition is very, very important. It's good that we have people on board who listen. That's number one. We have doctors on board who listen to patients when they come in. And that's the first thing that a lot of patients tell me, they feel heard. Because most times they have gone from doctor to doctor and they're just brushed over. They're just told, well, I'm going to put you on this pill or I'm going to give you this certain medication. And again, I don't know that it is a fault of. It could be that we need a bit more education as it relates to the condition. Funny enough, I was watching Grey's Anatomy on Thursday night and it actually had, you saw it, I'm not sure if you saw the episode, right? And they were dealing with endometriosis on it. And what was good about it was that, from the time the patient came in, they described their symptoms, the doctor was able to ask or assess and say, you may have endometriosis. Now, they weren't sure, but because of the signs and symptoms that the patient had, they were able to assess and say that. And then they went further and then they realized that's what it was. So that's what I'm saying. It maybe more education is needed, maybe more research is needed to be put out there, but a multidisciplinary approach to this condition is very, very important.
Yes, Dr. Barker, anything to add?
Yes, the multidisciplinary approach improves outcome. One story I would say is that you must listen to patients because more than likely, first appointments usually last about 45 minutes. Or it could be more, and this would be, most of it is just listening to the patient and it's teasing out not just one diagnosis. Sometimes you might listen to a patient and you say, hang on, you have 4 things wrong with you there. And then you try then to figure out which one is the worst one and you try and sort that one out. So sometimes it might take you 2 or 3 months to actually, siphon off the 43 different disorders, because one patient of mine had endo and she had bladder issues, likely IBS, and list goes on. So some of them can be quite complex. So then you have to send them to the urologist who would see what is happening. And then at surgery, you might need 2 or 3 people plus the psychologist before. So it's a multi-pronged approach. Usually by the time the patients get to me, some of them are broken, unfortunately. And most of them will tell me, well, you're the first to listen, in terms of not dismissing. And that's the thing, you might listen to somebody and you might be listening to them, but the way how you might look at them, the patient might say, well, this body ain't listening to me. Yes, you might be looking at them, but what the effect of what you showing them, even though you might be listening to them, the patient might think otherwise. So essentially, it's all about listening to the patient and then planning proper in relation to a plan, a management that the patient is actually involved in, and actually listen to their aspects or their side of the disorder as if they're happy with what is going on. But the multidisciplinary approach is the best way forward. And as I said, you was always hear me say it improves the standard and level of care and the actual outcomes. And there's no point of reinventing the wheel. Overseas, UK, you have endometriosis centers, and they go by certain protocols, so there's no need to actually reinvent the wheel. What I would say is that where we benefit from most people is that we have psychological support. Most centers overseas might not have a psychologist as an integral part of the team, and that I have seen. So I think we are off to a good foot in Barbados in relation to managing this disease.
Yes, that is very, very true. Question back to you, Mrs. Roach. When should a woman seek assistance from a mental health professional? And should a family member then intervene if that person may not want to seek assistance, but they think that they should?
Very, very good questions. Okay, so I think that for a woman, you always have to listen to your body, go with your gut, and determine whether you are receiving the support that you need, whether there is support out there that may benefit you to help you through the process. Now, what I can say is that originally, I don't think a lot of people knew that there was support out there for them, right? When I was battling endometriosis myself, I didn't even know they had a center in Barbados, the Barbados Association of Endometriosis and P.C.O.S, right? And so I looked for support through overseas means, so joining groups overseas, whereas we have a center here that deals with that, right? Support is very integral, and mental health support is even more integral in managing this condition, because it is crippling. It's crippling chronic pain that women go through. Some people may not believe that it's so crippling and debilitating, but it is. It results in absenteeism at work because you cannot function. It results in social lives being uprooted because, of course, you have to think long and hard, and you have to plan a lot in order for you to be able to go and have a good time with friends and family. And because it takes so much out of you, most times you just don't bother, right? Because it's too much work, right? So seeking mental health support is so, so very important, especially too when you are surrounded by friends who maybe have good periods, so they don't even know when their menstrual cycle is coming, right? That used to tick me off a lot. I had to come to terms with that myself. But yeah, so they don't even know when their menstrual cycles are coming. They don't get any pain, nothing. Whereas a woman with endometriosis now, she may know a week in advance that it's coming. So, you know, already your mind is already set to this impending pain that's going to happen, this doom and gloom mindset, right? And so that helps to change your thought processes, your thought patterns. And so you need to seek help when that happens. There's also that feeling of being disappointed in yourself, feeling as though you're letting yourself down, right? Because you can't function like other women within society. You can't do the things like other women in society. So that's also a sign when you should really seek mental health support. Misunderstanding in relationships, for example, can be extremely difficult for a woman battling endometriosis when you have a partner who is just not understanding what is happening to you. So you're trying to explain it, but then maybe they don't believe you. Maybe they think that you just don't want to have sex with them anymore, because painful sex is a part of it as well, right? And so as opposed to, I have a headache all the time, right? No, I have a stomach ache now, and they really just don't understand it. So, you know, that misunderstanding and miscommunication within your relationships, that affects relationships. Family members who you would think should know better. That's something that happens as well. And being able to verbalize your pain. Sometimes we have friends who may not know how to sit with us in our pain, who may not know the right words to say, or who may not know how to just behave or react to you when you're in pain. And maybe all you want to do is just cry. You just want somebody to just be there for you, not even say anything, right? So I think that those are instances where you should seek mental health support. As it relates to your second part of your question, where you spoke about, family members, I think that's what you said. Yeah. Right. So I think if you can get family members to come in and have a discussion when you're having your discussion with your doctor, and they will come, I think that that's important, because I think even Dr. Barker, he does not mind explaining things to a partner in the room with the patient as well, because I think it helps them to understand that you're not imagining what's happening with you. Everything that you are going through is something that has happened to women before, so you're not alone in your struggle, you're not alone in your pain. And so I think if a family member can come in, even into a counseling session with the client as well, and the client is willing and open to that, I think that that is very important as well.
Okay, so I'm sure a lot of persons who would be watching this session, they would take note. They would really take note to your words. And support, as you said, is very, very important. When I first found out that I had endometriosis, I was like, what is this? Like, am I the only person living with this condition? But as you said, I found BAEP. And then I realized, I'm not the only one going through this. And I know a lot of times, even now, there are women who think that they're by themselves. They think that this is just them. So it's very, very good to hear you say that, support is one of the main things that a woman would need. Now, is there any assistance publicly to women who may be having psychological issues?
I would say yes, in terms of you can find a psychologist on your own if you want to. You can find a psychiatrist as well. So those will be private means, but then publicly, you can go to the polyclinics, have psychiatrists on board. And they also have, are they psychologists? I think they are. I can't swear to it, but I know for sure they're psychiatrists within the polyclinic system. So for any mental disorder that you may be experiencing, or any mental illness or mental challenge, you can go to the polyclinic and be seen. There's also the QEH, Queen Elizabeth Hospital, so you can go there as well. There are mental health professionals associated with them, and the psychiatric hospital as well. A lot of people don't like to go to the psychiatric hospital simply because of the stigma around it, but there are mental health professionals at the psychiatric hospital as well.
And now that you have said stigma, I find as a society we have this whole thing, stigma around periods, stigma around mental health, and it's very, very heartbreaking because many persons lose their lives just for going through issues, not being able to talk about it, not being able to. I'm seeing a psychologist or I'm seeing a psychiatrist. Would you say that you find persons telling you a lot when they come to you, or they didn't want to come to you at first?
Yes, I definitely get that, especially with the men, surprisingly enough. Yeah, but yeah, I do get that because, again, like you said, the stigma and the taboo surrounding mental health is still there. It's still prevalent. I do think that we are improving. And I think with COVID has helped that come along as well, because, having to sit with yourself at home, just seeing the same four walls or being around family members that you're not accustomed being around with so often, it has helped to improve that and change that a little bit. But I still think we have a long ways to go in terms of mental health, and we have an even longer way to go as it relates to menstrual cycles and talking about them publicly, which is why I'm glad we have such forums as this, that we can have these discussions. And I think men should come to these types of discussions and listen to these types of discussions as well, because it's important for them to understand the female anatomy, number one, and to understand how a woman feels, what she's experiencing. It's important for women too to come and listen to these forums as well, because oftentimes, and especially within Barbadian society, we know that sometimes we say some things that are pretty cruel, and you may not intend for them to be cruel. Just like Dr. Barker was mentioning, your affect and how it comes across. Your words matter, and what we say to each other matters. So I think if we can all just be kind to each other, be careful about what you say and how you say it to others, because women can be triggered for any number of reasons, right? Especially going through such a debilitating condition, such as endo.
Yes, that is true. And my last question to both of you, well, not question. Question. What would you say to a young woman now coming up and having challenges, what would you say to her? Dr. Barker, you want to go first?
Yes, my advice, if you have any, essentially, if you're having any constant pain throughout the month that's getting worse with your periods, constant intermittent pain getting worse with periods, painful sex, painful periods, any bloating or anything like that, my advice would be to see a professional. And if you don't get answers or you don't get the answers that you want, please get a second opinion. Because what we have to realize is that the average time for diagnosis is 5 to 7 years, which is a long time for people to be in pain, and painful periods enough to stop you from doing your normal activities is not normal. So that's why I say to go and see a medical professional, either a GP first, and then go from there.
Okay, thank you, Dr. Barker, for your words. Brenda?
Yes, and I would reiterate exactly what he said. Painful periods are not normal. We have grown up in a society where we were thinking that it was normal, but it's not normal. Having those excessively heavy menstrual cycles, that's not normal. Feeling that stabbing pain in your stomach every month, that's not normal. That bloating that Dr. Barker spoke about, again, that is not normal. Painful urination, because that happens as well, and painful bowel movements. You know, you have to get that checked out. Speak to your parents, your guardians, advocate for yourself as much as possible. And when I say advocate, I mean speak up. If it is happening and you are not feeling comfortable with it, if it's happening and it's really too painful, it means that something is not right. And so speak up, advocate, and get your parents to get you to come and see a doctor, like Dr. Barker said, a GP first, and then you can go and see a gynecologist afterwards as well.
Thank you so much, Brenda. I want to thank both of you for being here tonight. I'm sure that persons who will, watch this session, they would have retained a lot of information, a lot of information. And I'm sure that we'll have you back some other time to speak about, maybe something else along the line, probably P.C.O.S, because we also advocate for other gynecological disorders. And I want to thank those viewing for joining us on this episode of BAEP Talks With. See you soon. Bye.
Bye.